All right. Well, hi everyone. I'm Dan, one of the PGY5 residents. I'd like to welcome and thank Dr. Goltigan for taking the time to work on this. We really appreciate these, and they're very high quality and educational for us.
You're welcome.
Okay, so we're gonna do 4 cases. We're gonna do 4 cases. I'm gonna pick one resident per case, just to help because I can't see people on Zoom. So Damien, are you on?
Yep.
Okay, great. So this first case is for you. This is a 33-year-old man. He saw a neurologist because he was having worsening headaches, history of migraine headaches, but otherwise healthy person. On physical exam, he has left beating nystagmus, maybe a little bit of slight ataxia, but otherwise he's neurologically intact. What would your next step be for him?
I definitely get some imaging given the kind of worsening symptoms, and I guess are the symptoms, these like worsening headaches, different from his migraine like symptoms in the past?
They're different, and let's say they're a little bit worse in the morning.
Okay. Yeah, I mean, you could start with a CT, I guess, just to be, maybe more cost effective, but ultimately probably an MRI is going to be more high yield. To fully characterize
Okay,
whatever's going
great.
on.
So he got an MRI. Great. So he got an MRI. Tell me what you see, like the type of sequence and if it has contrast or not, and then kind of what you see.
Sure. On the right side definitely looks like it has contrast, with a contrast in hair with a lesion in the cerebellum, left cerebellum. The left side though doesn't look like a contrast in T1 to me.
Left does have contrast.
That is okay. All right, so they're all it's what I suspect is a contrast enhancing lesion, and I guess kind of CP angle on the left side. But mostly, I would say
does it
rising
look
from
like
the
it's
cerebellum.
intraaxial or
Intraaxial.
perfect? And maybe a little bit of involvement of the medulla and lower brainstem here. Like it's kind of like, I would say mainly in the cerebellum. I agree with you. Kind of involving a little bit the medulla and lower brainstem as well. Do you think that he has hydrocephalus?
Not based on those images, and the fourth is like pretty wide open.
Yeah, I would say it's facing the fourth. I don't see any like obvious frank hydrocephalus, but it's definitely, obviously anytime you have a posterior fossa tumor, you want to be alert for hydrocephalus, especially when people have headaches. So any thoughts of what this could be like? I guess what's your differential diagnosis for this scan?
I guess because it's kind of involving sort of the fourth ventricle there, maybe like a ependymoma, or some sort of like glioma, like kind of astrocytoma or something in the cerebellum. Honestly, beyond that, I'm not too sure.
So ependymomas are usually in the ventricles, right? And you mentioned that you think this is primarily coming from the cerebellum. So I think that's less likely, but just what are some things that are homogeneously enhancing in the posterior fossa?
I'm not sure.
These are like things that you say every day during
I
conference.
mean, like an astrocytoma, glioma.
Okay.
I think
I mean,
pediatric.
I think it wouldn't be a meningioma given it's intraaxial.
Yeah. Okay, so for posterior fossa lesions, so the guy's 33. He's not a child, but he's pretty young. Do younger
the
people
JPA.
have any? Sorry.
The JPA.
That's one. Yeah, that's definitely one good one. Any other lesions that are kind of not specific, but pretty predominantly in the posterior fossa?
Angioblastoma.
Uh-huh. And then any other malignant ones that we see all the time in like adults?
Like a
Met, yeah. And then, well, you said astrocytoma, but yeah, I was thinking glioblastoma.
In adults, you can see hemangio. What can you see? Hemangioblastoma, maybe in the cerebellum.
I think he mentioned hemangioma.
You mentioned that.
Yeah.
Okay.
Yeah.
So yeah, I mean, hemangioblastomas and pilocytic astrocytomas are like typically cystic with a mural nodule, but they don't have to be.
Okay.
Perfect. And because it's neuropath, you know, these are hard things.
You can also see ganglion cell tumors, both in the brainstem and cerebellum.
One more question, actually, Damien. So let's say that this was a pilocytic astrocytoma, what would you see on a CAT scan, or like what finding would point you more towards pilocytic astrocytoma?
On a CT scan. Usually, I mean, there would usually be like a cyst with a mural nodule. Can they be calcified? Is that what you would see on a CT? I'm not sure what like CT finding you would see, but
yeah, I guess they're just going for cystic, but okay. So this guy had a what approach would you take to get to this this tumor?
I don't know. Maybe like a retrosig.
Why don't you bump it up, Dan?
Okay, sure. Is Kat on? I mean, I think he just said it, but
I'm here.
hey Kat, what would you so I guess what would you think about doing for this guy?
So sorry. Could you just go back a slide a little bit? Looks like there's a posterior fossa mass at the pontomedullary junction inferiorly on the left, contrast enhancing, and yeah. So I think that we need to at least biopsy this. That would be where I would start. I don't think we should resect it.
Yeah, I think that's reasonable. I mean, obviously, different people are going to have different opinions, and I welcome other opinions. But seeing how this is kind of exophytic and potentially involving the brainstem, I think it's reasonable to find out what this is. Just see if it's how aggressive or benign it is. So, I mean, in any case, so this person had a left retrosigmoid craniotomy and then had a biopsy. And I guess a maximal safe debulking. And then this is the pathology.
Yeah. So I'll while you move the slides, I will talk. So this first one is a good example of one of the caveats in neuropathology. In this particular case, because of the surgical approach, I suppose there was a lot of normal cerebellum in the beginning. It was one of the frozen sections. So this is how normal cerebellum looks like. If you don't know that the lesion, the normal cerebellum has granule cells, which you see on the bottom right corner, that crowded blue areas in the lower right corner represent normal granule cells. Yeah, let me see if I can point.
I'm sorry.
Oh, yeah. So this was the smear on the left also represents normal granule cells. So this is not tumor. This is, you could mistake it for a tumor.
I'm right here. Oh, I was sitting right there with you.
Okay, can we go on?
Hmm?
Hello?
This slide or the next slide?
No, this is fine. So this is the tumor as opposed to the previous slide. This is the smear of the tumor. This was a later specimen, and you can see here, a crowding of nuclei, slightly more spindle shaped. Next. So this is the permanent, and you can see a mildly cellular lesion with fibrillary background, mild atypia, and that pink structure towards the middle left of the slide is a Rosenthal fiber, and you will see better examples of that. There are no mitoses. There's no vascular proliferation. There's no necrosis here. Next one. So you can see a bunch of Rosenthal fibers here. Rosenthal fibers, when you see them in the context of a posterior fossa tumor in a younger person, you have to think of pilocytic astrocytoma. Okay, and this is what it is. Next. Another area where you see some hyalinized blood vessel walls, typical for slow-growing tumors on the right upper area. And on the left lower area, there is calcifications. You were mentioning calcifications before. Next. Anything else? Oh, so it's a glial fibrillary acidic protein positive, and the cells are typically elongated, bipolar, bland cells with two processes, bipolar processes. Next. And the Ki-67 is very, very low, close to 0. So this was called a pilocytic astrocytoma. I'm not sure if molecular testing was done, because in posterior fossa, you can see BRAF duplications, characteristic for pilocytic astrocytomas, which would support the diagnosis. And of course, absence of aggressive histological features, typical pilocytic morphology, and absence of immunohistochemical, indications of a diffuse infiltrative glioma, such as p53 positivity, ATRX loss, IDH1 positivity. All of these are absent in this case, which also contributes to the diagnosis by elimination. Okay, so that's the histology.
Perfect. So this, as Dr. Goldingen said, was a pilocytic astrocytoma. These are WHO grade 1 tumors. The subtypes include optic gliomas, hypothalamic gliomas, and cerebellar pilocytic astrocytomas. And then PCAs differ from regular astrocytomas that we sort of see every day in terms of their reduced tendency to invade tissue and low propensity for malignant degeneration. So they have a much better prognosis than infiltrating or diffuse astrocytomas. So they're kind of a different beast. These are the most common astrocytic tumors in children. Average age is lower than for typical astrocytomas. So 75% of the patients that have these are younger than 20 years. And they're actually the principal CNS tumor associated with neurofibromatosis type 1. So they're predominantly in the cerebellum, like a plurality, I guess you would say, but they're also in the cerebral hemispheres. Optic gliomas and hypothalamic gliomas are types of, they're just sort of different names depending on the location of pilocytic astrocytomas. So these optic gliomas are what makes NF1 have a high association with pilocytic astrocytomas. And they can also arise from the brainstem and the spinal cord as well. So it's reasonable to also get hand CNS imaging just to make sure there's no other lesions or drop metastases. Molecular genetics, as Dr. Goldegen said, the most common mutation is a BRAF mutation. And these are actually most common in cerebellar pilocytic astrocytomas. And that's obviously important to check because there are BRAF inhibitors like dabrafenib, so that can potentially guide therapy to have the molecular genetics involved. And then, as I mentioned, so the NF1 gene is mutated in patients with neurofibromatosis type 1, and they can have bilateral optic gliomas. Pathology, so they're called pilocytic astrocytomas. Pilo means hair because they have cells with long, thin bipolar processes. They also have these Rosenthal fibers, which are sausage or corkscrew shapes, eosinophilic inclusion bodies. And they stain like very bright red on mass and trichrome smears. And then they also have loosely knit tissue comprising stellate astrocytes with microcysts and occasional eosinophilic granular bodies. So these are very characteristic looking histology tumors. Radiographic appearance, as I mentioned, a lot of the plurality have enhancing cysts with enhancing mural nodules, but they don't have to. They can also have a solid mass with minimal or no cyst. And then treatments. So if they're cystic with a mural nodule, you want to resect the nodule only. The cyst wall is not neoplastic. If it enhances, it's from inflammatory changes, not from a neoplastic process. You just take out the mural nodule. And then there is some kind of back and forth about timing of radiation, but I guess typically people say that you delay radiation unless there's progression. If you have a gross total resection, I guess it could be reasonable to radiate if you have a subtotal resection, but you could also still wait and see if it grows. And then as I mentioned, you can treat with dabrafenib, which is a BRAF inhibitor, if they have a BRAF V600E mutation. Okay, cool. So next, this is for Sumed. Are you on? Victor?
I'm here.
Okay, perfect. Thanks, Victor. Good morning. So this is a 38-year-old healthy male. He has a history of Hashimoto thyroiditis. He was a research volunteer. He was a volunteer for a research project here at UM, but he had no symptoms, neurologically intact. He had so this is his initial MRI. This is from 3 years ago. So tell me what you see.
See axial images, contrast enhancing lesion in the left cerebellum, CP angle.
So yeah, so this guy has there's
Sorry, and there's others. Sorry, I'm seeing all the different slices. There seems to be multiple contrast enhancing, well circumscribed lesions, 2 in the cerebellum at least.
yeah, and these two are kind of looking at the same thing, but they're all in the cerebellum. There's so this is one. There's one here, as you mentioned, sort of close to the CP angle, but 2 in the cerebellum, and then this is a third one, kind of high up in the cerebellum. And what MRI sequence is this?
It's a T1 contrast enhancing.
How can you tell that it's with contrast?
The vessels are lighting up.
Perfect. And so when we don't always go through this and say this, but when you say it's contrast enhancing, you really should be comparing it to T1 and then seeing if it starts lighting up in comparison to the T1. So what sequence is this?
That's a T1 non-con.
Right. And how do you know it's non-con?
Oh, I can't see any vessels lighting up.
Perfect. And then also sometimes the nasal mucosa can be bright. I mean, that's another way of looking with contrast. But so what are okay? So there's 4 things. There's contrast, and then 4 other things that are bright on T1. Do you know what those 4 things are?
T1 fat, bone, protein.
But so bone does not it's not bright on T1, but it has something that is bright on T1. It has marrow, which has fat, so that's why bone is bright. So you mentioned fat and protein. So
Blood and melanin.
perfect, excellent. So why do you think this is bright on T1?
It could be blood or melanin products, I guess.
Sure. So this, I guess they initially, I mean, this is sort of like, hindsight is 2020, but I guess initially they thought this could be a meningioma because it sort of looks like it's coming from the dural edges, and so they follow this, and then I guess 3 years later they grew in size. So what if it were melanin? Or I guess what's your differential here?
Metastatic melanoma, metastatic yeah.
Okay, that's a good one. Any other ones? Like maybe lower on the list?
I don't think it would be meningioma, but could that also be one? Because I don't know how much it enhances without contrast.
Yeah, I think it's like less likely to be bright on T1 without contrast, but it could be. I mean, they could be meningiomas just because of like the location. Okay, but yeah, I like the differential so far. I mean, there's other things that we'll talk about in a second. So what would you
Has the clinical exam changed, Dan?
exam has not changed.
I guess from a
He's the same.
diagnostic
growing.
perspective, you would perhaps try to biopsy perhaps the superficial lesion to perhaps better guide management.
It's true that you want to kind of target your surgeries towards people that have symptoms. Like having like neurologic deficits is definitely an indication for surgery. Another indication for surgery is like growing lesions that are growing in size. So I think he's earned at least removing the superficial lesion and then seeing what it is, and then I guess going from there. And that's what they did. They did a suboccipital craniotomy initially just to see what it is and to figure out what's going on. And
Okay, so you can see we talked about pigmented lesions in the MRI. You can see that there's this diffuse brown pigment in this lesion. This picture is dominated by that. So it's a cellular lesion. It has pigment. And let's move to the next slide. Can you move to the next slide? Yeah. Okay, so you can see here typical melanocytes with granular brown melanin pigment, and the purple bluish nuclei you can see in the background where the pigment allows us to see them actually, and there seems to be mildly prominent nucleoli and pretty cellular lesion. But you can see that there is no mitotic figures, no necrosis. Next. Yeah, so this is a higher power. I deliberately shot this because the main differential diagnosis is melanoma. And although you see some prominent nucleoli, which is typical in melanocytic lesions, this doesn't have the big cherry red nucleoli of melanomas, most melanomas. And again, there is absolutely no necrosis, apoptosis, mitotic figures, which are more typical of malignant melanoma. So this seems to be a lower grade melanocytic lesion. Next. Here I'm trying to show that, remember the granular cell layer of the cerebellum that's in the middle? Those are not lymphocytes. And you can see that balls of this tumor are infiltrating into the cerebellum. So that's important to demonstrate because microscopic invasion of this adjacent parenchyma is a criterion for primary CNS melanocytic neoplasms, which this is an example of. Next. Here, this is actually a slide from the second nodule. I believe that was a second surgery sampling the second one of the 3 nodules. And this shows, in addition to others, necrosis. You can see these areas that are light pink at the top and at the bottom that represent necrosis. So that's yet another criterion for suggesting that this may be an intermediate grade lesion rather than a low grade melanocytoma. Next.
I guess that was
No, that's fine. Yeah.
Okay, great. So, this is a very rare and very interesting category of tumors. So this is sort of from a family of primary leptomeningeal melanocytic neoplasms. So this is actually very interesting stuff. And if you want to learn more, this review is excellent. So I highly recommend taking a look. So you may not know, but pigmented cells are normally found in the leptomeninges. They're most common in the leptomeninges of the upper cervical spinal cord and brainstem and posterior fossa. Melanocytic. So basically, what happens is during embryogenesis, you have these neural crest cells that end up migrating throughout the body. They go to the uveal tract, the skin, the inner ear, and the brain, specifically the leptomeninges. So you have these melanoblasts then turn into melanocytes. They can become neoplastic, and there's different names for how aggressive the neoplastic conditions are. So here's a great picture. So this dark staining on the brainstem is actually melanin. And you can see histologically that there's these pigmented cells here. So this is in normal people. We all have this. Again, they're most common in the upper cervical spinal cord and brainstem as well. So there's 2 categories of these leptomeningeal melanocytic neoplasms. So there's circumscribed and diffuse. So circumscribed are tumors that are, well, they're circumscribed, so they're not. They're kind of very contained. So like probably the MRIs that we looked at that have these very circumscribed discrete nodules are one of the circumscribed lesions. And then how you further name them is based on the aggressiveness. So melanocytoma is a benign or low grade circumscribed lesion. There's an intermediate grade melanocytic tumor, which is in between melanocytoma and melanoma, and then melanoma is the most aggressive. So if there's features of both melanoma and melanocytoma and you can't make a firm distinction between the 2, then that's an intermediate grade melanocytic tumor. So you can have a primary melanoma of the CNS. It's very important, however, because it's very difficult to distinguish like pathologically between primary CNS melanoma and cutaneous melanoma. So you have to do a very thorough like physical exam and skin exam and like look all over the body and see if there's any other sites that there could be metastatic melanoma from. So that's critical. So in contrast to the circumscribed lesions, there's also diffuse lesions, which are not so neatly packaged. Melanocytosis are cytologically benign proliferations of these melanocytes. They're benign, but they can still kind of involve the Virchow-Robin spaces, and if they spread very, very far and they start causing neurological deficits, they can actually have a poor prognosis. not necessarily from the aggressive activity of the cells, but just from the spread. And then melanomatosis is the malignant version of these diffuse processes. So it's the melanocytes become malignant, but they're not well contained, so they're diffuse. And these are most common in a genetic condition called neurocutaneous melanosis. So these kids have multiple nevi and melanoma on the skin, and they can also have it in the brain as well. So we kind of went through all of these things, but basically they're all, they can all have bad prognoses. Melanocytoma is probably the best prognosis, but it's very important to do a full workup and like look through the entire body, make sure there's no moles anywhere. Malignant melanomas require, I'm just kind of moving along for time. Malignant melanomas require postoperative adjuvant radiation as well as chemotherapy. That's important as well. And then they can have BRAF mutations. So if you do find that they have a BRAF mutation, then you can treat with dabrafenib, the BRAF inhibitor. Okay. Eva, are you on?
Yeah, I'm here.
Okay, great, thanks. So this is next case. This is a 21-year-old female. I think a year ago, her primary care doctor ordered an MRI because she had frequent headaches and she's neurologically intact. At the time, she had this lesion. She didn't have, yeah, can you tell me what you see?
Yeah, so can you pull up the contrast image?
She didn't have one. This is all that she had.
It looks like it's on the T1, it's kind of heterogeneous, hypo and hyper intense, and then on T2, it's kind of iso-intense to the surrounding parenchyma. Given the location of the lesion, it's next to the septum pellucidum. It could be like central neurocytoma. And then she's like on the younger side, 21 years old. And so it could also be a meningioma or a cord plexus papilloma.
Great. Yeah, that's a great differential. Typically, do you know where the most common location of intraventricular meningiomas is?
So for kids, intraventricular meningiomas are in the atrium, and then for adults, they're in the temporal horn or lateral ventricle.
Yeah, perfect. So she got an MRI. So they decided to watch this because. Sorry, last question. Do you think she has hydrocephalus or like a trapped ventricle?
It doesn't look like it on this sequence, but I guess I'd have to see like the third and fourth ventricle as well.
They all look pretty normal. So I mean, it's something that you think about, but well, didn't have it. She ended up getting another surveillance MRI a year later, while she was 24 weeks pregnant, and now it looks like this.
So yeah, it looks like the lesion's grown bigger in size.
Yep. And what do you think about this?
Oh, and then now it looks like her ventricles are larger as well.
Right. So that's kind of a concerning sign. So you mentioned the diagnosis. If you got a CT scan, what do you think it could potentially show?
If it was a meningioma, then you could show calcifications, and then.
And if it was a central neurocytoma, do you think it would show anything?
I think it would be iso-intense.
So intensity is for MRIs and density.
Sorry, iso-dense.
But central neurocytomas are they can have calcifications, so that you can see calcifications as well. Okay, so it's growing. She's pregnant. Her ventricle's getting trapped. What do you do?
I guess she's never had a history of like cancer or anything.
No.
Okay, and then she's 24 weeks, you said?
So which trimester or trimesters is it safest to operate if you had to operate?
I think it's the second, right?
Right, because
Either
why is it bad to operate during the first trimester?
Because that's when all the embryogenesis happens.
Yeah, so embryogenesis, organogenesis, those things can be interrupted from all the drugs and chemicals and stuff. So you don't want to do it at that time. And then why is the third trimester bad to operate during?
Just because they're, I guess, like they're anatomically, they're like a lot bigger, and then they're just closer to giving birth, and so you don't want to like put under, like subject them to any surgery that could maybe cause them to have like premature labor or anything.
Yeah, so you want to avoid premature delivery. That's like the main reason to not operate during the third trimester. So the second trimester is like relatively safe. Are there any like positioning considerations? I don't know if you've ever operated on a pregnant patient before, but any positioning considerations if you're going to operate on a pregnant person?
You would put them you would have them supine, I guess, or you could have them lateral decubitous.
Which side down?
The side of the aorta, like down.
Yeah, you usually put
Side.
the. Sorry, go ahead.
Left side down.
Yeah, exactly. So you left side down because you don't want to put pressure on the vena cava and the aorta. So you want to have like the blood flow and the blood drainage and everything optimized, and you want to have OBGYN like around and either in the room or have fetal heart tones being monitored and stuff. And then I'm really torturing you here. I'm sorry, but what are the, if you wanted to take this out, what are the two main like approaches, surgical approaches for this?
Could go interhemispheric transcallosal, and then you could also do, I guess, like transcortical.
Yep, exactly. Okay, you're doing an excellent job. Very impressive. Okay, so and this person had a transsulcal, I think they used brain path tubular retractor to get to this.
Okay, so this is a smear prep or a touch prep during intraoperative consultation. You can see there's this uniform round nuclei with the typical so-called salt and pepper chromatin. Salt and pepper chromatin refers to this stippled, finely dotted chromatin pattern, which is typical of neurocytomas. Next. So with an intraventricular tumor, that histological picture is classic for neurocytoma, and I think neuropathologists can suggest that during frozen section, and also radiology is typical in most cases. So this is the low power view. You see the same cells uniformly, dispersed over the slide here with some microscopic blood because of the surgical blend tag. Next. Okay, same thing here, uniform round cells with some clear cytoplasm. These were historically called intraventricular oligodendrogliomas because the morphology looks very similar to that of the oligodendroglioma, which used to be called the fried egg pattern. But someone realized that these were neuronal after examining electron microscopic pictures. Next. So this is interesting. Typically in the cerebellum, there's a tumor called, in the same family, called liponeurocytoma. Okay, and you can see in the center of the slide, in the middle of the tumor, there is actually some adipocytes. So this is interesting because you're not in the extracranial location. Normally, you shouldn't see fatty tissue, right? So this is actually a known and described situation. There's some metaplasia of this tumor producing a again, so-called the liponeurocytoma, typically in the cerebellum. Those are, again, commonly very slow-growing lesions. This one, I found this microscopic focus of lipoid differentiation. So I just wanted to show that as a curiosity. Next. I mean, you can think about corpus callosum lipomas, you know, how a nervous system tumor can have metaplasia to adipose tissue. Those are molecular questions. In neurocytomas, as you see in the center of this lesion, there is nuclear-free neuropil zones. This is not necrosis. And that's also a typical histological feature. At the same time, you can't keep but notice that there are two mitoses at the top and middle left of this photo. Next. Here you can see them better, two dark purple mitotic figures. Next. There's a vague area of necrosis in the center here. Next. And the tumor stains unequivocally with all neuronal markers, including NU-N, HU, and synaptophysin. So this is a neurocytoma, and you can see slightly, actually, I'm sorry, you can see the slight evidence of vascular proliferation here. The cells that do not stain, those are blue, and these are endothelial cells. Next, is there any more pictures? Oh yeah, the Ki-67 was distinctly high here, at least at 10% or more. So we suspected that this neurocytoma has atypical features, and atypical neurocytoma does not have an elevated WHO designation. In other words, you don't make them grade 3, but I couldn't help but note the mitotic figures, Ki-67 index, that separates this neurocytoma from the typical examples, typical low-grade examples. Okay. Next. So the mitotic figures are further characterized by phosphohistone H3 stain. In this particular area, there is at least 1, 2, 3, 4, at least 4 definite mitoses. So there are some mitotic figures which exceed, I think, the expected from the typical low-grade neurocytoma. Okay.
Okay, well, so I'll go through this quickly because I want to have time for the last one. So central neurocytomas are WHO grade 2 neuronal tumors, generally attached to the septum pellucidum within the lateral ventricles. They can infrequently occur in the third ventricle. Most common in the third decade, but they can be seen in children and the elderly, and there's no gender predomination. As Dr. Goltagan mentioned, they often have a fried egg appearance on staining. And then it can also have calcification. So I kind of like imagine that like the shell of the egg is is the calcified thing that you're seeing on the CAT scan. That's how I remember it. And they have not seen 1p19q deletions in central neurocytomas, although you can see them in extraventricular neurocytomas. They have calcifications. Prognosis, the gross level resection can be curative, but there can be recurrence, and then radiation is controversial. We did a review and we found that adjuvant radiation reduces the risk of recurrence, but not overall survival. And then we talked about when to operate during pregnancy. So this is the last case. Mike Cater, are you on?
Yep.
Okay, cool. So this is a 21-year-old right-handed gentleman who presents with complaints of severe left neck, shoulder, arm pain, as well as a growing mass in the left supraclavicular area. He found the mass just by looking at himself, and over 3.5 months, noticed that the lesion has been growing, and he's been feeling numbness in his lateral arm, forearm, and hands, and some weakness, particularly in elbow flexion and extension of the hand intrinsics. So in a physical exam, he has weakness in the trapezius. His deltoid is 2 out of 5, 3 to 5 in external rotation, 3 to 5 in the rhomboids, winging of the scapula on the left. What nerve? I mean, just from the phrase winging of the scapula, what nerve might be involved?
The long thoracic.
Yeah, and do you know what muscle that controls?
Serratus anterior.
Yep, great job. 1 out of 5 in the biceps, 3 to 5 in the triceps. He has 4 to 5 in the wrist extension, finger flexion, and hand intrinsics, and numbness in his C6, 7, and 8 dermatomes. And then on examination, he has a large tender to palpation tumor extending into the posterior triangle of the neck, as well as palpated in the axilla. He has pectoralis muscle atrophy on the left, as well as the deltoids and biceps. Sorry. What would you what would your next step be?
I would probably get a MRI of the cervical spine and probably include the brachial plexus.
Okay. So here's your brachial plexus MRI. What do you see?
Oh,
So large enhancing mass with lots of flow voids in there. I guess my differential at this point would be neurofibroma, malignant nerve sheath tumor. I'm wondering if it's also involved in the, or I guess a schwannoma, if it's involved in the bone, maybe aneurysmal bone cyst or giant cell tumor. Hard to say off an MRI. A CT could also be helpful to look at the bony anatomy.
Do you think it's something based on the history? Do you think it's something that's benign or malignant?
Probably benign, just because it sounds like it's been over a course of a long period of time, and it's gotten to this size, and he hadn't noticed it until now.
So I guess two things that kind of stand out to me are it grew significantly over 3.5 months, which I think is kind of a short period of time, and also it's like very painful. So I think those things, when I hear those things, like generally pushes me towards suspecting something that's malignant. He had a biopsy at an outside hospital just to see what it is, which I think is reasonable to know what you're dealing with before you have a definitive treatment. And then he had this resected. It was like a multidisciplinary surgery, supraclavicular, intraclavicular exploration, decompression of the brachial plexus, and resection of the tumor. So this is what the pathology showed.
yeah. So I was able to get the outside needle biopsy here, and this was a soft tissue case, and I wasn't able to get any other pathology until today. Did you? I'll describe what I see here, but did you look at the resection?
These were just the two that I had
Okay.
from the email.
So anyway, what this shows is a typical desmoid fibromatosis, which is a deep example of the fibromatosis. And you can see a pink collagen background and very fine tapering spindle-shaped nuclei. And this would be supported by a nuclear positivity for beta-catenin stain. And of course, along with negativity with muscle markers and other types of markers such as CD34, they should be negative, but beta-catenin should be positive. This would support desmoid tumor. Desmoid tumor typically, can be superficial, like the plantar and the hand varieties versus the deep fibromatosis, which you can see in young women in the abdomen. You can also see examples in the retroperitoneum. I didn't have access to the resection specimen, so that's it. So it was benign, sort of benign, because it can be locally recurrent.
Okay. So desmoid fibromatosis tumors are rare intermediate grade neoplasms. They don't metastasize. They're extremely rare, 2 to 4 cases per million. Some of the risk factors include high estrogen states, the surgical scars, and the, genetic association is familial adenomatous polyposis, FAP. They're more common in females, as mentioned. Estrogen is a predisposing factor. And it used to be thought that they were active fibromatosis, but through genetic analysis, they've shown that there's chromosomal abnormalities. So these are actually clonal neoplasms. And they have a very high recurrence rate after surgical resection. Especially desmoid tumors of the head and neck have probably the highest rate of recurrence. And that's probably because there's so many important structures. It's harder to get a gross total resection in that area. So they're hard to cure. And sometimes they're groups with like low-grade soft tissue sarcomas. They're benign, but can be extremely locally aggressive. They lack a true capsule, and they can extensively invade surrounding tissues. So these are like one of the benign tumors that you don't want to have. Histology, they have spindle cells, rare mitoses, copious stroma. They are thought to arise from the musculoaponeurotic tissue, and they don't have any characteristics of high-grade malignancy. They can occur anywhere in the body, but they commonly occur in the extremities, trunk, musculature, head, neck, and abdominal cavity. And the literature kind of like talks about abdominal desmoids separately because they have a different kind of course and stuff. And standard of care is gross total resection with wide margins. And although the recurrence rate is very high, with up to 70% of patients having recurrence, having a large resection with wide margins lowers the recurrence rate. And if you cannot get wider aggressive margins, then you can treat with adjuvant radiation therapy. Medically, there's interesting medical therapies. So giving anti-inflammatory medications like COX-2 inhibitors has been shown to sometimes lead to tumor regression. Estrogen blockade, I mentioned that it's an estrogen responsive tumor, so they've given tamoxifen. And then there's been some anti-sarcoma chemotherapy agent not trials, but like attempts to treat with like different chemotherapies like ifosfamide, etoposide, dacarbazine, temozolomide, and then kinase directed therapies such as imatinib and sorafenib. And that's it. So great job to the residents.
Great job, Dan, for doing that. I was just going to make a couple of comments about the desmoid tumor. This was Ian Cote's case, and he did a phenomenal job along with Dr. Nguyen with resection. The comments are, like you said, they're super rare, so nobody has an enormous experience with them. They can present in the brachial plexus, but they can present anywhere. And the reason why they're so difficult to resect is because they're usually hard as a rock. There's no CUSA, there's no Sonopet that's going to help you here. It's usually sharp scalpel dissection, and where you don't get the scalpel and you end up retracting the nerve roots a lot. And so it's not uncommon to have increasing neurological deficit. I just reviewed a paper for neurosurgery from the Chinese. And as you can imagine, it's usually the Chinese who have the greatest experience with any rare lesion because of their referral pattern. And I think they had like about 20 cases. And because recurrence was so common, they would commonly sort of bundle the neurovascular bundles in a collagen wrap, expecting, recurrence. And then, finally, I sent you a review paper, which is not really surgically oriented. It's more sort of holistic on every aspect, including medical treatment and the genetics of desmoid tumors. And it's a review from Mayo Clinics. And it was actually sent to me by a patient I was following who's a cardiologist who has a lesion that's been there for years and years. And he's obviously very not really eager to have it removed. So, not all of them present like this particular case, which apparently was growing quickly. Some of these patients have the lesions for years without much growth. So there's definitely a role for just careful observation.
Thanks. We'll definitely take a close look at the review you sent. Thanks for sending that.
Well, we have a special guest lecturer that's going to start at 8 o'clock. I know that Antonio is already on. Is there any other?
Hey, everybody.
Hey, good morning. Buona mattina.
Morning to you.
Dr. Iavarone is currently a professor at Columbia University, but just in terms of a background, Dr. Iavarone attended Catholic University in Rome, did his MD, did a residency in pediatrics and pediatric oncology fellowship, and then came to the US in the early 90s and did a 4-year research fellowship at the Brain Tumor Research Center in San Francisco. And that was followed by another fellowship at Memorial Sloan Kettering. And then eventually went back to Italy, came back to New York to start his research career, and has been at Mount Sinai, but most recently for many, many years has been at Columbia University, has a phenomenal neuro-oncology research program. And he really is an expert in the genetics of glioma, has multiple publications, including in Nature and PNAS, New England Journal of Medicine. And so it's a real honor to have Dr. Iavarone speak to us today. Thank you, Antonio.
Thank you, Alan, for the great introduction. I guess I'll try to share my screen now. Let's make sure that you guys can see my slides. Can you see my slides?
Yes, we can, doctor. It looks beautiful.
Wonderful. Thank you. Thank you very much, everybody. It's a real pleasure to present to your grand round and try to give you an outlook of the programmatic activity we do here at Columbia, especially along the integration of translational research and how all this information is driving clinical application. As you see in this initial slide, the primary trajectory of our work is combined an integration between computational analysis that has primarily worked to drive new discoveries that then we try to mechanistically validate and expand in multiple models and ultimately deliver accurate information into the clinic. This is happening primarily in the context of this physical science and oncology center that I direct here at Columbia, that includes 10 investigators working in different aspects of computational, experimental, and clinical work. So I don't think you guys need a long introduction on the clinical features of malignant glioma, just to say that different than many other cancer types, these tumors have seen very little improvements despite aggressive therapeutic attempts, including not so well characterized, as you will see, precision therapy approaches. And obviously the primary reason for why these tumors, as you all know, are very aggressive is because they have a very high ability to proliferate and multiply and ultimately grow from their initial location. So, of course, I don't think that there is a better audience to whom to indicate how important, of course, is the extent of tumor resection in terms of impact on survival of these patients. These results come from an MD Anderson cohort of patients, but obviously have been reproduced by many different studies. However, despite the complete resection that can be accomplished in high-grade glioma, we all know that there is no such thing as a normal brain, unfortunately, in a patient with glioblastoma. And in this schematic diagram, you can see the fact that in autopsy studies, you can invariably identify tumor cells even in the contralateral hemisphere from the tumor mass that, of course, may be present at a low rate, but that ultimately are able to generate recurrences at different locations. So the ability to invade the normal brain is clearly the primary hallmark of aggressiveness of GBM. And this feature has been recognized for a long time and actually has been the primary biological hallmark that has initiated the trajectory of our journey in these tumors. Again, a trajectory that has outlined the combination of computational biology with experimental work and then clinical repercussions. So this work started in the period around 2007, 2008, and was primarily focused on trying to identify what we now know as master regulators of the mesenchymal signature of a high-grade glioma. We were talking about ability to invade the normal brain, canonically accepted. Then you will see that now the picture is changing, but what has been canonically accepted in GBM biology is that the ability to express genes and markers of the mesenchymal lineage has been interpreted as the primary driver for invasion of the normal brain. So this subtype that was defined in 2006 by Ken Aldape and Heidi Phillips, the mesenchymal subtype, has been viewed as the most aggressive subtype of GBM. So when we started this work, next generation sequencing approaches that now have become so important for our work as well as the one of many others had not started yet. So we developed actually a computational approach that is based on a reverse engineering algorithm that you see depicted here, that was defined as Arachne, whose goal is the identification of master regulators of the mesenchymal signature of high-grade glioma. And we came up with two of these master regulators, transcription factors, STAT3 and CBP beta, that turned out to be both sufficient and necessary for the activity of the mesenchymal phenotype in high-grade glioma. You can see that the analysis of STAT3 and CBP beta in primary GBM was sufficient to predict the poor outcome that we knew was associated with these tumors. As the technologies then became available, we formed the first team to essentially analyze by next generation sequencing a large data set of GBM that were available for both exome as well as RNA-seq to identify the primary genetic drivers of this disease. And this work was done by basically preempting, if you want, the work that was then done by TCGA. So we reported through, again, a combination of computational and experimental work that there are multiple drivers that you see indicated in this graph, where we report both gain of function alterations, those indicated in green, as well as loss of function alterations, those in red. And then we validated a number of them, some of the most novel and significant alterations that are those shown here in right. And as you can see, all of these new genetic drivers of GBM converge on the ability to trigger this very aggressive phenotype of GBM that now is considered as probably the main culprit for recurrence and resistance to therapy, that is the ability to retain this tumor stem cell state, this glioblastoma stem nest state that allows repopulation of tumors even after cytotoxic therapies. And I'm not going to spend too much time to describe these alterations, just to say that some of these are incredibly interesting. Yes? Somebody want to say something? I guess no. Okay, so some of them are extremely interesting and are being pursued now mechanistically. Some, for example, this LZTR1 is the a ubiquity ligase adapter that is mutated in the germline also of patients with schwannomatosis, to indicate the connection between somatic alterations that we find in these tumors and, as you will see, those that are found in the germline. But I wanted to make a small deviation in the discourse to actually discuss very briefly about some drivers of this glioma stem cell state that you will hear in the seminar of Dr. Lasorella, I think next week at the Cancer Center. Our lab has been studying ID proteins that stand for inhibitor of differentiation. They are the primary mechanistic effectors of normal stem cell, because ID stands for inhibitor of differentiation, and we and many others actually found that they are also primarily responsible for this cancer stem cell state that I was describing to you before. And as I said, you will hear, especially in the connection with cancer, much more from Dr. Lasorella. The reason why I wanted to make this brief departure from the genetic and biology of GBM is because I know that there are important players of the Miami project there, and the ability to manipulate neurons to actually reprogram them into an axonal growth mode that could be exploited for axonal regeneration purposes is clearly one of our goal of our lab. You see, we wrote a review a few years ago following a paper we published in 2006, in which we showed that exactly these factors that prevent premature differentiation of neurostem cells in the normal brain are actually effectors to promote axonal elongation. They are progressively lost as neurons reach their target and extend axons. And we were able to reprogram damaged neurons even in the presence of negative effectors such as myelin when we were introducing this degradation-resistant form of ID2 in damaged neurons. So this was published a few years ago, but now I think this field has been actually rejuvenated, if you want, because there have been now a number of studies that have indicated that the cocktails that have been borrowed actually from the Yamanaka factors, the factors that have been primarily used to induce IPS, induced pluripotent stem cells, when introduced into neurons, they can promote this axonal growth mode. So now there are a number of clinical trials that are attempting to do gene therapies with AAV virus, adeno-associated viruses, and we and others have shown that in fact in vivo these degradation-resistant forms of ID2 are able to extend axons in lesions of different type of axonal degeneration conditions. So I am sure that we will have the opportunity to discuss more about this, because this creates, I think, a very exciting potential connection whereby the same targets that you want essentially to destroy in cancer can be exploited for axonal regeneration purposes in diseases of, for example, spinal cord injuries. So let's go back to the cancer field. Everything we discussed before concerns high-grade glioma, but beside the highest grade tumors in the brain, there are low-grade tumors, and in 2015 we essentially joined then the TCGA, and we reported what is now the WHO classification of low-grade glioma that, as you can see, is primarily driven by the state of IDH mutation, and then is subclassified based on the 1p19q codeletion. So each of these three groups, the 1p19q codel, the 1p19q intact IDH mutant tumors, and the IDH wild type, are associated with a specific set of divergent genetic alterations, of associated genetic alteration, and each of these groups is associated with a different probability, a different pattern of evolution into more aggressive tumors. Following the report of the lower grade glioma, then we decided to generate a new working group, again in the context of TCGA, that we called panglioma. And the purpose of this group was to assemble the largest cohort of gliomas that was available at the time. As you can see, it reached the number of over 1,100 glioma of any grade. And we have been able, thanks to this large data set, to identify different types of different subtypes, both within the IDH mutant and the IDH wild type, using a classifier that is primarily based on DNA methylation. So a very important point I want to make for all of you is that right now, as some of you may know, the ability to profile gliomas for their DNA methylation has become a primary knowledge, a primary output to actually properly classify these tumors. And as I was saying, within the IDH mutant subtype, in addition to what was essentially known as the primary subtype that now became known as GSIMP high, GSIMPs stand for the glioma methylator phenotype, that is the hypermethylation condition that is causally consequent to the IDH mutation. We were actually able to identify the group of GSIMP low that is a small but significant subtype that, as you can see, is associated with a much worse clinical outcome compared with the rest of the IDH mutant subtype. And now we know that this GSIMP low is actually characterizing the progression trajectory of the IDH mutant GSIMP high. So these tumors are reached at recurrence following therapy of an IDH mutant GSIMP high. Within the IDH wild type, we identified also an outlier group that we called as PA-like, to stand for Pilocytic Astrocytoma-like. This is an adult tumor that has features very similar to that of a pilocytic astrocytoma of children. And as you can see, these tumors, different from the rest of the poor prognostic IDH wild-type subtype, are associated with a relatively more favorable clinical outcome. Now, the reason why this DNA methylation is so important is obviously not only the ability to classify tumors in bulk tissues, in tissue specimens, but also in collaboration now with Utan Nushmer. This has been exploited. This is very recent work that we just reported to basically extract signatures that then can be used to obtain cell-free DNA in blood for detection and monitoring of glioma. So essentially, using methylation profiling, we have been able to do what has been very challenging to do so far, that is to with genetic alteration, so that is to identify in a reliable manner a signature that has essentially 100% sensitivity and specificity for the specific detection of glioma in blood. And as I was saying, not only this is important for the detection of this tumor, but is, I think, probably even more important for the clinical management and the follow-up of these tumors, because although in a limited data set, we have seen that by using this GAL-B score, GAL-B stands for Glioma Epigenetic Liquid Biopsy score, we have been able to deconvolute the state of pseudo-progression that, as you know, is a challenging condition, so that many times results in unnecessary resections of treated patients. So in this particular case that you see here, the lesion that was interpreted as a recurrence underwent resection that was associated with absence of active tumors, and this condition was correctly predicted by the GAL-B score as absence of tumors, because as you can see, this score had decreased very significantly to a non-tumor state from the original baseline. So this is an extremely active area of research in our group, and we are now trying also to generate signatures that can obviously capture specific subtypes of gliomas and generate windows of opportunity even before surgical procedures. We were discussing about the fact that the work that we have done so far has been primarily focused on somatic alterations in tumors, but we know that there are conditions that predispose patients to develop glioma. These type of conditions have been specifically excluded by the TCGA by eliminating all known genetic predisposition in the cohort of patients that had been analyzed by the TCGA group. So we felt that after completing the work with the sporadic tumors, we had now to form a network to study what is the most frequent genomic predisposition of glioma, that is the neurofibromatosis type 1. Obviously, this is a multi-disease syndrome characterized by different tumor types, but in addition to tumors in the peripheral nervous system, these patients have a high chance to, high probability to develop different type of gliomas, mostly in children, but also in adults, and some of them can even be aggressive tumors. Again, I am just giving you a flavor of the type of work that we have done. Then I am happy to discuss offline about more details. But last year we reported the landscape of gliomas both in children and in adults, high grade and low grade, in patients with an F1. And as you can see, we have been able to identify modules of genetic alterations that characterize high-grade glioma in NF1 patients, as well, that are completely different from those characterizing low-grade glioma. In particular, the high-grade includes this module of p53, CDKN2A, and ATRX alterations in the absence of any IDH1 mutation, whereas the low-grade essentially doesn't have this alteration, but has primarily alterations of the MAP kinase, FGFR pathways. The other very important and translationally significant finding is the fact that different from, as you will see, the primarily immunosuppressive microenvironment that we find in high-grade sporadic glioma, in patients with low-grade glioma, specifically in the low-grade group, we found two different subtypes. One that we defined as a high immune and one that we defined as a low immune. And the feature of these two subtypes is actually the fact that the high immune contains a high number of infiltrates of CD8 T cells that we believe may be effector T cells that could predispose this particular subgroup to immune therapies. This is the key follow-up that we are now continuing to work on, and in particular to determine the clinical significance of this high immune subtype that we identified. So I guess at this point of my talk, I have to basically say that everything you heard so far clearly is extremely superficial, because everything you heard concerns the fact that we typically analyze the tumor mass without taking into consideration either the trajectory of evolution that often is quite dramatic under therapy, in the sense that these tumors tend to change both in terms of loss and gain of features, of molecular features, but also the fact that depending on where we resect, obviously, the biopsy that then we analyze at the molecular level, we can actually identify a formidable level of spatial heterogeneity. And I'm going to tell you a few things now about how we are trying to resolve these both temporal and spatial heterogeneity. In terms of temporal evolution, we reported a large data set for genomic analysis and genomic and epigenomic analysis of matched primary and recurrent cases of GBM that you see indicated in this slide. And without going into detail, the key initial finding that emerged from this study that now is widespread in terms of reproduction by different groups is the fact that approximately 15% of GBM recur, those with this black bar, with this hypermutated state, with often over 1,000 mutations that have been interpreted as primarily driven by treatment with temozolomide. Not only, of course, we know that there is this hypermutation state, but as you can see in this three-dimensional bubble plot, we could, thanks to this temporal evolution dissection of these tumors, essentially list, subdivide the alterations among those that are truncal, that are common between primary and tumor, those that are present only in the initial tumors and then lost, and those that characterize many more tumor recurrence. You can see that, for example, some alterations on which many, probably too many, clinical trials that have failed so far have been focused, in fact, are alterations that are that tend to be lost at recurrence. The FGFR3 TAC3 is something we will discuss later in the talk, but I think especially for this audience is extremely important to highlight how informative can be a navigation guided biopsy of multiple regions, typically core and rim of tumors that can correspond, in the case of GBM, typically to contrast enhancing and non-contrast enhancing. So this type of biopsies can be extremely informative, especially if they are in turn combined with single cell sequencing of each of these biopsies. And here you see some of the analysis that can actually illuminate our understanding of GBM biology when analyzed by single cell sequencing. Here, this is a topology data analysis that is a computational technology developed by our group, where just to give you an idea of the complexity of GBM, a GBM that is classified as a proneural, that here is indicated in blue, from a mass analysis, from a bulk analysis, in reality at the single cell level is identified with a gradient of transcriptomic states that goes from the typical proneural state up to the opposite mesenchymal state that are those indicated in red, including the many intermediate states that clearly characterize the majority of cells. So single cell sequencing is now a technology that is heavily used in our group, and as you can see here is especially providing information for the composition of the GBM microenvironment that, as you know, is characterized primarily by this vast majority of immunosuppressive myeloid cells, macrophage, and as well as microglia that, as we were saying, in sporadic GBM are associated with a very strong immunosuppressive microenvironment and are probably the primary culprit for the systematic failure of immunotherapies that so far have been reported in GBM. Clearly, the analysis of single cell sequencing can provide us incredibly important information on the crosstalk between tumor cells and non-tumor cells in the microenvironment. So here you see again an example of this, where the tumor cells indicated in red produce a cytokine, CSF1, that is a very important trophic and growth factor cytokine for the blood-derived macrophages that are those in green that express the CSF1 receptor. So we invariably find that when we have highly CSF1 expressing tumor cells, we also have consistently microenvironment associated with the CSF1 receptor macrophages associated with them. By combining these spatial and temporal deconvolution, as well as the deconvolution of the microenvironment and of the neoantigenic structure of these tumors, we can generate these evolutionary trees, such as the one that you see in this slide, in which we can, for example, study 5 different specimens of tumors from one single patient. And these tumors in this particular case were generated from the original primary tumor, from the recurrent tumor, and from a second recurrence, what is called post-recurrence here, both in the core as well as in the rim. And here you can see, really, we don't have to go into detail. I'm just showing you the incredible complexity of alterations that we identify in these tumors, each of which, of course, can be responsible for a particular mechanism of evolution and eventually a particular therapeutic approach to counteract this mechanism of evolution. So, for example, in addition to the truncal alterations that are present in each single biopsy, we could see this mechanism of immune editing, where we identify what we call as a high-quality neoantigen, a neoantigen that is very likely to generate an immune response that corresponded to the transformation of the microenvironment into a highly immune microenvironment consistent with the presence of this high-quality neoantigen, that then was lost, as you can see, as the tumor evolved into the final lesion, both in the core and in the rim. So we are now trying to identify recurrent pattern of spatial and temporal evolution by analyzing much larger cohort of tumors that have been explored using exactly this same technology. And the reason why this is so important is, again, because this can provide extremely informative action plan for clinical applications. Here, for example, you see the summary of a study that we did in collaboration with Do-Yoon Nam in Korea, where we analyzed the different types of lesions, either present as local multiple regions, locally adjacent in the tumor mass, or distant multiple lesion, and then recurrences that were local recurrences or distant recurrence. And then what we could actually estimate is that the divergence in terms of genetic alterations is directly proportional to the physical distance in these lesions. So, for example, in these distant multiple lesions and in this distant recurrence, we find a clonal events that distinguish these particular lesions from those that instead are characterized by a more local pattern of tumor development or tumor recurrence. The reason, again, why this is important therapeutically is because all these private clonal mutations that can be identified when then are being targeted in models of these tumors that were generated from these tumors actually were unable to generate effective immune response. Whereas only the shared lesions that, as you can see, are those indicated in green and yellow, in particular
alterations of the PI3 kinase pathway and the FGFR3 TAC3 fusion are those that resulted in successful sensitivity to targeted drug. So clearly our ultimate goal is to provide paradigms for how this complexity of molecular alterations should inform clinical decisions. And this is just an attempt to do just that using the information that we discussed before. And is basically the fact that if we recognize genetic alterations as branches, secondary branches in the tumor evolution pattern, these secondary branches are unlikely to generate significant responses because obviously the other part of the tree is going to replenish very quickly even the most successful targeting of this branch, whereas our goal remains that of targeting truncal alterations that should be and can be identified with all of the tools at our disposal. And here I want to enter into something that is more related to precision medicine, that is the fact that all this information can be utilized to overcome the challenges that currently limit the application of successful precision medicine paradigms that have primarily been associated for reasons that sometimes escape my imagination to a concept of one regimen fitting for all, and then we see what happens and we decide what to do later. I think that we could do much better than that, and the primary driver to do just that is to try to abandon the idea that we should treat GBM using the whole pool, the entire pool of patients. And on the other hand, we should try to identify small but extremely homogeneous subtypes of high-grade glioma patients and clearly determine the accurate tumor addicting features of these tumors using all the tools at our disposal. So this is one example of the state of precision medicine of glioblastoma today, the fact that some of the most frequent genetic alterations in GBM, like EGFR, have been pursued with many different clinical trials using both small molecule inhibitors, antibodies, and so on, all of which resulted in invariable failure. And there are probably many reasons for these failures, but probably the primary reason for that is what we discussed before, and is the fact that these tumors are extremely heterogeneous, and in particular, in the case of EGFR, the EGFR alterations are almost never truncal alterations. They are typically subclonal alterations that, as you can see here, are indicated by positive tumor cells harboring EGFR amplification, neighbored by tumor cells lacking EGFR alterations, but exhibiting alterations of many other receptor tyrosine kinases that clearly will be resistant to all anti-EGFR approaches. So when we started to think about what could be low-hanging fruit to characterize small but homogeneous subgroups of GBM, we thought that the best example of success for targeted cancer therapy in other tumor types was characterized by the presence of chromosomal translocation that generate gene fusion that, for example, in CML have completely changed the trajectory of clinical treatment of these patients with the targeting of the BCR-ABL chromosomal translocation, but also in the case of solid tumors, the same thing has later happened with the identification of the ALK fusion that is present in 3% of non-small cell lung cancer. So we started a project that was specifically aimed at the identification of oncogenic, recurrent, and driver gene fusions in GBM. From this project that lasted a number of years with a number of reports, we identified 3 types of recurrent fusions that you see indicated here, all of which are targetable, and some of which, in particular the FGFR3 TAC3, is now being pursued by us and many others, and as one of the most promising low-hanging fruit target for an homogeneous driver alteration in GBM. We found this fusion in 3% of IDH wild-type GBM, but now this fusion is viewed as the single most frequent gene fusion across all human cancer, because as you can see, similar low-frequency population of patients with this fusion have been identified essentially in every single type of solid tumor in human patients. In collaboration with Marc Sanson at the PT-Salpêtrière in Paris, we recently have characterized the molecular and clinical features in a large patients with these fusions, and we could actually detect a significant, more favorable clinical outcome associated with this fusion that actually is an independent prognostic factor in a multivariate analysis that basically identifies these IDH wild-type FGFR3 TAC3 patients as an intermediate outcome between the large population of FGFR3 TAC3 negative patients and the IDH mutant group that is the most favorable. So as I was saying, these fusions provide us with very good opportunity for targeted therapy. And here you see in this intracranial model of patient-derived cells harboring the fusion, how effective this inhibitor of FGFR, this irreversible inhibitor of EGFR, TAS120, has been in reducing tumor expansion as well as extending the survival of these mice. So we developed recently a clinical grade screening assay for the identification of all the possible isoforms, all the possible variants of these fusions that have breakpoints in different positions of these 2 genes. And recently this screening assay that is based on an RT-PCR as well as on an immunostaining to actually highlight the pervasive expression of this fusion in essentially 100% of the tumor cells. This assay has been recently approved as a companion diagnostic by the FDA for treatment of urothelial cancer, that is one of the tumors with the largest fraction of these fusions. One criteria to clearly indicate the value of a target in GBM is the fact that these should be retained under standard of care treatment at recurrence, so that you can be confident that treating even at recurrence tumors that at diagnosis harbored that particular alterations actually can still retain high likelihood of success. And this is the case for this particular type of fusions, where recurrent tumors were equally positive for the fusions when the patients showed positivity at diagnosis. One of the most interesting inhibitor targeting FGFR receptor kinase is this compound called erdafitinib that, as we were saying before, has actually been approved by the FDA for urothelial cancer, and in fact is the one that, as you saw in the previous slide, gave us the best result so far in mice, and is also the one that in in initial clinical attempts has shown promising effects in patients with recurrent GBM treated at the PT-Salpêtrière in Paris. So right now there are a number of clinical trials that obviously are ongoing, some of them in GBM, but most of them in many other tumor types that clearly represent easier targets, as usually happens when pharmaceutical companies have to decide whether to invest in brain tumors versus other tumor types. But the reason why I'm showing you this slide is because in these basket trials that typically have included many different types of genetic alterations targeting the FGFR genes, the tumors showing positivity for FGFR3 TAC3 have essentially been those with the best responses observed. So clearly, these are at this moment low-hanging fruit that we believe now we can target in many different ways. And in the last 10 minutes, I think I should be able at least to tell you the mechanism of action of this fusion that now very recently has actually triggered a different line of investigation in our lab that is now a new and more, if you want, sophisticated ability to classify GBM. But the reason why these fusions are so important is not only because, of course, they provide exceptional opportunities for targeted therapies in GBM, but also because they have a very unique mechanism of action that we reported a couple of years ago as a mechanism that is directly engaging mitochondrial biogenesis and oxidative phosphorylation as the mechanism to provide energy support to expanding tumor cells. This happens through a very complex signaling pathways that starts from the phosphorylation of specific substrates by the FGFR3 TAC3 receptor tyrosine kinase fusion protein, and that ultimately results in the activation of a master regulator module for mitochondrial biogenesis and OXPHOS activation. Again, this type of, if you want, basic science related information is directly providing, immediately providing opportunities for therapeutic target. Because as you can see, if now we use models, glioma models harboring the FGFR3 TAC3 fusion, and we treat these models with inhibitors of oxidative phosphorylation, some of which are very classical drugs, some of which are new drugs, as you will see later, these type of inhibitors are specifically active only in the models harboring FGFR3 TAC3 and not in those harboring other type of oncogenes. And here you can see in mice that these effects are very pronounced. So by now targeting the downstream mechanism of action of this fusion, we can observe significant anti-tumor effects that are completely independent from our ability to directly target the fusion protein with an FGFR kinase inhibitor. And here comes the, I guess, the new concept to target not only the precision medicine specific driver that is the FGFR3 TAC3, something that we can do obviously with the small molecule inhibitor or with antibodies now, but that we know based on many other targets in this way that mechanism of resistance will ultimately be generated. We believe that we can to preempt this mechanism of resistance by combining an FGFR inhibitor with an inhibitor of the mechanism of action that is inhibitor of oxidative phosphorylation, such as metformin, that in this case basically prevent the development of resistance to the FGFR inhibitor. So I guess, Alan, I can use the last 5 minutes or we can go to questions right away. I believe that you guys have patients in the operating room waiting for you. So I don't want to abuse your time, but please let me know how I should proceed.
No abuse at all. We love it. And maybe just stop at 8:55. We'll have 5 minutes for question. How does that sound?
Okay, sounds great. So I just use then the last 2 minutes to say that actually we recently explored, this is a work that was published last week, we recently exploited the information that in addition to this very small subgroup of patients with the FGFR3 TAC3 fusion, we actually were identifying a much larger group of patients that we found harbors this oxidative phosphorylation signature. So we tried to improve the current classification of GBM using information from single cell and from bulk tumor analysis. And as you can see here, this new classifier has recently been reported, and the primary, I think the most important direct finding is that we identified a subtype of GBM that we call as mitochondrial GBM, is a group that is specifically dependent on the ability to express mitochondrial genes and is associated with a better clinical outcome compared with all the other groups. Now, the reason why the identification of this mitochondrial GBM is important is again the fact that exactly as I showed you before with the fusion, we can actually target mitochondrial GBM with specific inhibitors. Here you see a new inhibitor targeting complex 1 of mitochondria with these inhibitors of oxidative phosphorylation. And you can see that if now we use PDX models that are classified as mitochondrial, we have a very strong anti-tumor effect with this inhibitor of oxidative phosphorylation, something that, of course, we never see if now we use PDX that are instead classified as glycolytic plurimetabolic. So this is the very last slide of my talk that basically is simply trying to give you the message that you can have the most accurate prediction of success in the case of precision therapy of GBM only if you are able to extract and validate all the possible informations concerning the pattern of dependency of tumor cells and of the interaction with the environment. And prominent among all the features that now we can study actually where each single patient becomes a project is our ability to target not just genetic drivers. Of course, when genetic drivers are there and are important, they provide opportunities for targeting, but we can target mechanism of action. We can target phenotypic states that very often involve the metabolic dependencies that are present in these tumors. And I cannot overemphasize the fact that an incredibly important tool in all this paradigm is the availability and our possibility to generate and study in real time patient-derived tumor models in which we can perform personalized screen before informing accurate therapy in real time. Here you see the list of people who are working with us to translate our finding into the clinical setting, again, using a combination of primarily discovery-based computational approaches and experimental validation in multiple systems. Thank you again for your attention.
Thank you, Antonio. Any questions?
Hi, this is Macarena de la Fuente. I have a question. I think it was a fantastic talk, as always. It's a pleasure to, listen to you. Just like a broad question. So, what do you think we as neuro-oncologists need to do differently? Because despite all this information that has become available over the last decade or so, we keep doing these negative clinical trials, basically getting all our trials with not really positive results for our patient. I think you touch base on some of these things, but maybe you can elaborate a little more about that.
So I think the first point is really the idea of exploiting windows of opportunities in patients, starting to basically study these patients even before surgical intervention. And I think with this liquid biopsy, cell-free DNA, we are actually moving in the right direction to not only obviously make a diagnosis of gliomas before surgery, but also to be able to actually have an information about what kind of glioma we have. We are now at the stage of understanding whether we deal with an IDH mutant or an IDH wild type tumors. But for example, we are now already studying the possibility to understand whether we have an FGFR3 TAC3 positive glioma. And so with our neurosurgical friends, I think we have to make sure that they are fully engaged to work with us to clearly study these tumors, not only with the complete resection that we all want, but also, for example, to do those phase 0 studies that clearly can be initiated even at the first resection stage in these particular cases of windows of opportunity. So that's definitely one point, basically be ready to do the right thing before a patient is operated. The second point is that when the patient is operated, everything that comes from the operating room is incredibly precious. Not only, of course, to allow us to publish papers and to write grants, but actually to provide potential therapies in a real time frame. There should be 1 to 2 months that goes from intervention to when we can come up with ideas for therapeutic opportunities. And as you know very well, especially in the group of patients with unmetilated MGMT, I think we do have the opportunity to introduce rational therapies in the very beginning. And we can do that, again, by studying these tumors with all of these technologies we discussed, but more importantly, to let this technology to inform the therapies that we validate in the patient-derived cell models, of course in vitro, but possibly even in vivo in mice before we actually give these therapies to patients. I think the idea that I really would like to advocate is that GBM patients should not receive therapies that have not been rationally guided based on knowledge of that particular tumor. The divergence of molecular features of each GBM is too high to think that we can assume that a particular therapy that may work in one patient will work in another patient. I think this is really the key concept that, in my opinion, is the one that should guide all our clinical approaches in the future.
Thank you, Dr. Averone. That was a great talk. I really enjoyed listening to it. Just a quick question. I know that you were mentioning genomic drivers and master regulators of GBM. How often, if we sample, these tumors in the operating room, and are we able to identify master regulators in these tumors, with single cell RNA sequencing? I guess my question is it feasible to do that, in a prospective fashion?
So the short answer is in 100% of cases, in the sense that if you want to know what is the set of master regulators that characterize a particular tumor, both at the single cell level or at the bulk level, you can do this for every single patient. Now, this does mean that identifying the master regulator means that now you have a successful therapy. And that's the point. I mean, the computational work is incredibly important to provide information that should be experimentally, functionally tested and validated. Some of them may be targetable, some of them may not, some of them will be successfully targeted, some of them will not. For example, in the case of this mitochondrial GBM, we found that this, I didn't have time to discuss it, but PGC1 alpha is the primary master regulator of the mitochondrial state. If we abolish PGC1 alpha expression, both pharmacologically and genetically with the CRISPR mechanism, we can completely eliminate the ability of this mitochondrial GBM to grow. So that's definitely the case, but again, this may apply to particular type of tumors, and I don't even know if this applies obviously to every single patient that is classified as mitochondrial GBM. So I would really advocate that even in very simple paradigms like this, there can be extremely divergent heterogeneity in terms of pattern of response. It doesn't mean that all the mitochondrial GBM will respond equally well to treatment with anti-mitochondrial drugs. Some will, but some may not, because they may already have, inside of the tumor molecular profile, the alterations that allow these tumors to evolve into a glycolytic, for example, tumor type that is clearly much more aggressive. We can learn these things in a model, and we can be ready to treat these patients, knowing that we have to be more aggressive in one case and less in another case.
Appreciate it. Thank you.
All right, Antonio, that was absolutely incredible talk. We super appreciate it, and thank you for doing grand rounds.
Thank you again for having me.
Gracias.
Bye-bye.
Bye-bye. Very enjoyable. Fantastic talk. Thank you.
Thank you.